Welcome, nursing students, to today's high-stakes clinical explainer. We're going to walk step by step through a rapidly evolving patient deterioration. As a nurse, you're the absolute first line of defense. You're the eyes and ears right at the bedside, and your ability to spot subtle and honestly the not-so-subtle changes can literally mean the difference between life and death. Today, we're breaking down a simulation of a patient crashing into hypovolemic shock from a massive upper gastrointestinal bleed. Let's get into it.
So let's set the scene right away. Imagine you're on the floor and this critical alert suddenly pops up: active haematemesis and hemodynamic instability. The sheer urgency here tells us this isn't some slow-moving chronic issue. No way. This is a massive, acute event happening right in front of you. When you see a warning like this, your clinical brain needs to instantly snap into emergency response mode.
Here's our shift planner for today. We'll quickly hit the patient profile, the pathology, recognizing deterioration, critical labs, urgent interventions, and finally, the isobar handover. Starting with Section 1, Patient Profile, Gerald O'Malley. Meet Gerald. He's a 72-year-old retired farmer with a history of osteoarthritis, GERD, and type 2 diabetes. But pay close attention to his social history. He's incredibly stoic. As a nursing student, you probably already know the classic stoic farmer trope, right? They'll look you dead in the eye and say they're perfectly fine while their vitals are absolutely tanking. Patients like Gerald compensate and hide their discomfort right up until their body just completely crashes. Also, check out his lines. He already has 2 large-bore 16-gauge IVs and an NG tube in place. That is going to give us a huge head start for resuscitation. Moving to Section 2, the pathology, specifically ibuprofen and bleeding. So how did we get here? Well, Gerald managed his chronic back pain with high-dose ibuprofen, a super common NSAID. But the devastating consequence here is an acute upper GI bleed. Chronic NSAID use is just notorious for eroding the stomach's protective mucosal lining. Over time, all that ibuprofen literally chewed right through his gastric mucosa, eventually hitting a blood vessel and setting off this massive bleed. That's what caused his initial fainting and melaena. Let's recap his ED journey. Gerald showed up after passing out, having melaena, those dark, tarry stools full of digested blood. He was pale, clammy, and his initial hemoglobin was 82 grams per liter, which is already dangerously low. The ED folks stabilized him with a 1-liter fluid bolus and some IV Pantoprazole to suppress the stomach acid, with a plan for an urgent gastroscopy. He seems stable enough at that moment, but as we know all too well, stability in healthcare is sometimes just a temporary illusion. All right, Section 3, recognizing clinical deterioration. It's now 13:15 on your shift, and things go sideways fast. Gerald has 2 rapid episodes of haematemesis. And look at the progression. It goes from coffee ground emesis, which is older, digested blood, straight to bright red blood. That sudden shift, massive red flag. It tells us the bleeding is fresh, active, and heavy. Plus, Gerald is suddenly agitated and diaphoretic, meaning he's sweating profusely. And listen, that agitation isn't just him being anxious. That is his brain literally screaming for oxygen because his blood volume is dropping so fast. Check out these new vital signs. His heart rate shot up to 138, severe tachycardia. His heart is basically running a marathon, desperately trying to circulate whatever blood volume is left. Meanwhile, his blood pressure has completely bottomed out to 82/45. This is the textbook definition of profound hemodynamic instability. Gerald is in hypovolemic shock. The tank is empty and the pump is failing. Let's look at Section 4, interpreting the critical labs. The latest labs just came back and his hemoglobin plummeted from 82 down to a terrifying 68. This number is a huge wake-up call. It confirms exactly what we suspected from the bright red vomiting: massive, active internal blood loss. At 68 grams per liter, his blood simply doesn't have the oxygen-carrying capacity to keep his vital organs alive. And if you needed proof of that organ starvation, here it is. His venous lactate is elevated at 3.9. Remember, lactate builds up when cells are forced to make energy without oxygen. So this spike proves his hypovolemia is causing really poor perfusion and severe tissue hypoxia. His whole body is under immense metabolic strain right now. So let's stop and think for a second. Put yourself right there in the room with Gerald. As a nursing student, what is your immediate clinical reasoning telling you to do next? He's agitated, bleeding out, and his pressure is crashing. You can't just wait around for a doctor to stroll by. You've got to act. Section 5, urgent critical nursing interventions. Let's talk action. Priority number 1, absolutely always the airway. When you have a patient actively vomiting blood who's agitated and likely going to drop their Glasgow Coma scale, your brain needs to scream airway protection. The risk of him aspirating that blood into his lungs is huge and often fatal. So your immediate move? Grab the suction, clear that airway, and start prepping the room for an emergency intubation.
Priority 2 is fluid resuscitation to fight off that hypovolemic shock. We've got to manage this extreme hemodynamic instability. Thank goodness we already have those two 16-gauge IVs, right? You need to open those up to maximize flow. But here's the catch. His hemoglobin is 68. Normal saline isn't going to carry oxygen to his organs. You need to urgently prep the blood product administration sets because you'll be hanging emergency blood any minute now.
Priority 3, and it's a big one, strict documentation. Look, in the total chaos of a code or an emergency, it's so easy to push this aside, but it's absolutely vital. The medical team relies entirely on your strict input and output tracking. You have to record the exact volume of the emesis and melaena, and don't just put a number, document the nature of it. Was it 200 mils of coffee ground or 400 mils of bright red? That specific data dictates exactly how much volume Gerald needs to survive. And finally, Section 6, the Met Call Checklist. We're going to use the isobar handover framework for this. When you hit the button for a medical emergency team or Met Call, adrenaline is going to be pumping hard, and it's super easy to stumble over your words. Isobar is your ultimate step-by-step checklist to make sure you get the right info across quickly and clearly. Let's break it down. First, identify. This is Gerald O'Malley, 72 years old. Second, the situation. He's having an active upper GI bleed and is currently in hypovolemic shock. Third, your observations. Heart rate is 138, BP is 82/45, respiratory rate is 26, and he has active bright red haematemesis. Just like that. In 3 punchy sentences, you've painted a terrifying crystal clear picture for the team. Next, hit them with the background. History of NSAID use and GERD, admitted earlier with a hemoglobin of 82. Then your assessment. I believe this is an uncontrolled upper GI bleed leading to circulatory collapse. And finally, your recommendation. I am calling a Met Call. We need an emergent blood transfusion immediately and an urgent endoscopy right now. I really want you to notice that specific assessment line. Uncontrolled UGIB leading to circulatory collapse. That phrase is a total game changer. It perfectly sums up the exact pathophysiology of what's happening, and it tells the responding doctors exactly why every single second matters. Using language like that shows immense clinical competence. We've covered a ton today, from linking chronic ibuprofen use to a massive bleed, interpreting crashing vitals and high lactates, all the way to executing those critical, urgent interventions. So, I want to leave you with one final thought. Review that isobar checklist, trust the clinical reasoning you're developing, and ask yourself, if you faced a dropping GCS and active haematemesis on your very next clinical placement, are you ready to step up, take control, and save a life? Keep studying, keep asking questions, and I'll catch you in the next explainer.